So this is Chapter 16, Systemic Risk Factors that Amplify Susceptibility to Periodontal Disease. Systemic risk factors are conditions or diseases that increase an individual's susceptibility to periodontal infection by modifying or amplifying the host response to microbial infection. So you need two things to have periodontal disease. You need the bacteria and you need the host response. Systemic risk factors alter the body's or the host's response to the bacteria. So you have the bacteria, how you respond to the bacteria is what it affects. Some examples of systemic risk factors might be tobacco use, diabetes, stress. Those are the more common ones you're going to see. Let's talk a little bit first about diabetes. It's a chronic, lifelong metabolic disorder in which the body does not produce or does not properly use insulin. So how does it relate to periodontal disease? The prevalence of periodontitis is higher and the symptoms are more severe. And studies indicate that diabetes leads to a hyperinflammatory response to oral microbial biofilms and impairs resolution of inflammation and repair. So diabetes has an effect in a couple of different ways. You still have to have the bacteria. The bacteria still has to be present to have the disease. How the body or the host responds to the disease is what diabetes alters. And it can alter it in a couple different ways. It can cause a hyperinflammatory response. In other words, an over-exaggerated inflammatory response. So there's a lot of inflammatory cells that are released. Or it also can impair the resolution of inflammation and repair. So it can slow the repair process down. Glycemic control is one of the is what diabetes is. Individuals with well-controlled diabetes have no more periodontal disease than persons without diabetes, but individuals with poorly controlled diabetes are 3 times more likely to develop periodontitis. And individuals with diabetes and who smoke are 20 times more likely than non-diabetics to experience severe periodontitis. There are 3 types of diabetes. First type is type 1, and it's the less common. 5 to 10% of the population of diabetics has type 1 diabetes. It's caused by damage to the pancreas. So the pancreas does not produce enough insulin. Type 2 diabetes is the most common one. 90 to 95% of your diabetic cases are going to be type 2. It develops when the body does not make enough insulin. So gestational diabetes is the last type. Gestational diabetes occurs during pregnancy. So sometime during the course of a pregnancy, usually they'll do a blood sugar test on the pregnant woman and determine whether or not she's at risk of gestational diabetes. Glucose blood levels in diabetes. It is measured by something called a hemoglobin A1C or HbA1c, or we just abbreviate a lot of times and call it A1C. And A1C, what that measures is how much the level of glucose that's in the blood. 7% or less, or 7.0 is where you want to be. Anything above 7 is considered to be too much. It's considered to be uncontrolled. So a finger stick can be done for glucose levels, and an A1C is actually a measurement of your blood sugar over a period of time. A glucose finger stick measures the level at the current time. So patients oftentimes will have to stick their finger every day and do their measure their sugars or their glucose levels. But the A1C is something that's drawn like at a doctor's office, and it's measured over a period of time. Subgingival microbiota in diabetics, the composition is no different than a non-diabetic patient. So the type of bacteria and the amount of bacteria is the same in a diabetic or a non-diabetic, because it's the host response that is altered when a patient is diabetic. Wound healing is slower in patients that have uncontrolled diabetes. So if your patient has poorly controlled diabetes, you would want to maybe hold off on doing treatment that's going to require wound healing, like periosurgery, definitely not implant placement, even scaling and root planing. You can expect you're not going to get as good of a result as you would on a patient that has controlled diabetes. And somebody who has poor diabetes control is going to also have a relapse in periodontal disease much quicker. Other oral contraindications or other oral complications of poorly controlled diabetes is reduced salivary flow. So if a patient who has poorly controlled diabetes has a reduction in salivary flow, they're at a greater risk of an infection called Candida albicans, which is an infection that appears in the mouth as like it's like a white kind of yeasty looking infection, or a greater formation of dental caries. So they can, dry mouth allows for more plaque formation and dental caries. They are also more susceptible to abscess formations. They have more destruction of the alveolar bone. Chelosis, which is kind of a cracking like of the lips, or burning mouth and tongue. And these are some pictures of some localized swelling of an individual with uncontrolled diabetes. And you can see right here, there's the swelling on the palatal of the lateral incisor, or you got some swelling down here on the lower incisors. This is an over-exaggerated response to plaque in both of these cases. This little diagram just shows you the effects of uncontrolled diabetes. Altered inflammatory response. So defective neutrophil function in diabetics impairs initial immune response to infection. So neutrophils are PMNs. They're the first responders in the inflammatory response. So they don't respond the way that they should in diabetics. So their initial response to infection is altered. And then the hyper-responsive monocytes and macrophages in diabetics elevates production of pro-inflammatory cytokines. So that triggers, that defective neutrophil triggers a response that's altered in the rest of the inflammatory response. So the rest of the inflammatory cells, like your macrophages and et cetera, are all altered as well. There's an imbalance in bone destruction and repair. So they have rapid bone loss, or much more rapid bone loss. They have prolonged osteoclastic formation and activity. So remember, osteoclasts destroy bone. The role of AGE and RAGE, or age and rage, this is a little bit complicated. Just know that glucose in the bloodstream irreversibly attaches to proteins and lipids, forming harmful new molecules called advanced glycation end products. In health, AGE is at a low level. In hyperglycemia, AGE formation is increased. AGE degrades collagen and elastin. So those are fibers causing these fibers to harden and lose elasticity. So diabetics are more prone to eye diseases, kidney diseases, neuropathy, or nerve-related diseases. So these are just kind of side roles or side problems from diabetes. Implications for the dental hygienist. Utilize user-friendly self-screening tool for diabetes to identify risks. Educate about periodontal risks or uncontrolled diabetes. You're going to see a common denominator here for all of these risk factors, and that's going to be the term educate. So educating your patients whenever they have a risk factor involved, any kind of risk factor, is going to be number one. If the patient is aware of what to do, what to expect, how things can and can't go wrong, you're going to have a much more favorable, compliant patient. Interprofessional collaboration. You're going to work closely, your dental team, with other healthcare professionals that are involved in this patient's care. Oftentimes it requires discussions with physicians or nurse practitioners to find a good balance or relationship between the disease and how to manage periodontitis. Stress. Everybody has stress in their lives. You will definitely see patients who have reactions to stress. Patients are going along, they're a nice stable periodontal patient, and then one day they come in and they're showing more pocketing, more bleeding, more inflammation, and you start to talk to them a little bit about their life, and you find out that they're going through something really stressful. Hopefully, most of the time it's just an event that can eventually work its way out, but sometimes it's a long-term stress that they're going through, or an indefinite stress. They lose a job. They don't have any idea how long they're going to be unemployed. So you have to kind of work within the parameters to help them understand the effects that stress is having on their body. So acute stress can be immuno-enhancing, or it enhances or intensifies the operations of the immune system. So in other words, it triggers an immune response and a whole lot of inflammatory cells and immune cells are stimulated. In chronic stress, it can impair the physiologic regulatory mechanism that governs the immune system. Your body releases a hormone called cortisol, and it has anti-inflammatory and immunosuppressive properties. And so when patients become very stressed, the cortisol level is elevated in that response. And so it can cause anti-inflammatory and immunosuppressive properties to occur. So in other words, an exaggerated inflammatory response, and it can suppress the immune system all at the same time, which can cause periodontitis. Financial stress and depression are significant risk factors. What do you need to know? Periods of stress can cause suppression of the immune system and host microbial interaction in favor of bacteria, causing attachment loss. So good oral hygiene is about the best way that a patient can combat stress. You're not going to be able to control the patient's level of stress, and everybody deals with stress differently. So some patients will come in and they just always have something really stressful going on in their lives, but they deal with it really well, and you never see any changes. Other patients will come in and they'll have something that you go, really, you're stressed out about that? But their whole body has reacted. And stress can alter how people look after themselves. So in other words, sometimes when patients are going through a stressful or depressive time, they stop really taking care of their teeth. They stop flossing. Flossing is one thing that goes out the window pretty quickly when a patient becomes stressed. Hormonal variations. So we've got changes, 3 types of changes in the levels of the sex hormones. We've got puberty, we've got pregnancy, and we've got menopause. So we've got the early years, the middle years, and the older years. Puberty. Increase in hormones causes an increased blood circulation to gingival tissues. Increased levels may cause increased sensitivity to local irritants such as plaque. So during puberty, you will notice changes both in males and females in their reaction to plaque. They may have always had some plaque on their teeth, and now you're going to see the same amount of plaque, but an intensified or increased reaction. Pregnancy. It's important to educate, again, education, educate your moms about good self-care during pregnancy. We talked earlier about the pyogenic granulomas that can occur. Inflammation of the gingiva increases in pregnancy, and even in the presence of the smallest amount of plaque. And so gingival inflammation during the 2nd and 3rd trimesters, when elevated estrogen levels in the blood exaggerate the host response. During the 2nd trimester, associated with increased levels of Prevotella intermedia. So Prevotella intermedia is associated with the 2nd trimester and above in pregnancy. And this is a picture of pregnancy gingivitis. and this is a picture of the pyogenic granuloma, both of which occur during pregnancy as a result of the increase in the hormonal levels. Implications for the dental hygienist, you will needed dental x-rays, and use of local anesthesia is safe. Sometimes you'll want to do a consult with the medical doctor if there's any complications associated with the pregnancy, just to be on the safe side. Stress, meticulous daily self-care for biofilm removal. Their response to the smallest amount of biofilm can be exaggerated. So stress, meticulous oral hygiene. Let's see, chewing xylitol gum and lozenges reduces caries. That holds true for everybody. And keep in mind, frequent vomiting can cause erosion. So if the patient has suffered a lot of morning sickness, you'll want to consult them on how to combat that increased pH or decreased pH when they're vomiting. Menopause and postmenopause. Decreased levels of circulating hormones in menopausal and postmenopausal women results in oral changes. So postmenopausal women can suffer dry mouth, burning sensation in their mouth, altered taste, and then bone loss may be exacerbated. Menopausal gingival stomatitis is characterized by gingiva that bleeds readily and is abnormally pale, dry, and shiny. Osteoporosis and osteopenia. What are those two terms? Osteoporosis is a reduction in bone mass, making the woman more prone to bone fractures, and osteopenia is a condition in which there is lower than average bone density, but not necessarily an increase in risk or incidence of bone fracture. So osteopenia is kind of like a milder condition of osteoporosis. And this is a picture of what normal density of bone should look like. So right here, this would be like your young, healthy person, and you can see how there's very small trabecular pattern in the bone. And over here, you've got much more porous bone or more trabecular pattern in it. There's something called osteonecrosis of the jaw. This is something they discovered probably about 15 years ago. There's a medication category called bisphosphonates. You've probably seen commercials on TV for bisphosphonates that they would use to slow osteoporosis, and they found that it causes osteonecrosis. So it causes bone to grow, and that's what we want to have happen when a patient has osteoporosis, but it caused an overgrowth in the jaw, and so ultimately the jawbone would die off and it would turn into kind of like a mush. It's not very common, but it did spark enough doctors to take patients off of the bisphosphonates. Usually it was more common in the injectable ones where they inject like a high dose once a year versus like the daily oral medication that patients would take, but it really caused a lot of change in how doctors prescribe bisphosphonates. Menopausal implications for the dental hygienist: inform patients about osteoporosis and interventions such as calcium supplements and weight-bearing exercises. Stress meticulous self-care to avoid periodontal problems, and be aware of oral side effects of bisphosphonates. Again, educating your patient is the most important thing. Metabolic syndrome. We don't get too involved in metabolic syndrome other than knowing that any disturbances in metabolic control can lead to heart disease, strokes, and diabetes. Acquired immunodeficiency syndrome, or HIV infection. It's a communicable disease caused by the HIV virus. Oral manifestations, there's several of them listed here. Most of these you're going to talk about more extensively in oral path, so I'm not going to get into them too much here, but just be aware that there are these oral manifestations in patients that have HIV infection. This is a picture of that last one, this linear gingival erythema. So it's basically marginal band of intense erythema associated with HIV infection. Neutropenia. Neutropenia is characterized by abnormally few numbers of neutrophils in the blood. So as we know, neutrophils are the same as PMNs. They are the first responders in the inflammatory response. So abnormally few numbers of them would increase the susceptibility to infection because a lot of your first responders are not available to fight infection. Down syndrome. Down syndrome is a genetic disorder that happens before birth. It's a chromosomal disorder. You're going to talk a lot about Down syndrome in special needs next term with Professor Tressner, so we're just going to touch on it very lightly. I put in red the things you'll need to know for this class. The other stuff is just FYI information for you. Leukemia. Leukemia is a blood disorder. It shows up in the gingiva as swollen, glazed, spongy tissues, red or purple in color. Xerostomia is common. You will not see, hopefully, a lot of leukemia patients in practice. Just be aware, as far as the implications for the dental hygienist, is look for spontaneous gingival bleeding and enlargement. That is not explained by anything else. Usually this would be the patient that the amount of plaque that they have on their teeth does not equal the amount of redness and gingival bleeding and inflammation they have. And so that is kind of a trigger. Effects of oral medications. So a number of medications used to treat systemic conditions can cause oral complications, such as alteration of black biofilm composition or pH, effect on salivary flow, and effect on gingival tissues. This number 2 right here, the effect on salivary flow, is the one you're going to probably see more commonly. When you have pharmacology, you'll study this more in depth, but there are a lot of medication categories that decrease salivary flow, and they're common medications. So alteration of plaque biofilm composition. Sugar-containing medicines can alter plaque composition, metabolized by bacteria, and demineralizes the enamel, such as cough drops, cough syrups, tonic, vitamins, anything that a patient would, like cough drops that they suck on for any prolonged period of time, can lower the pH in the mouth and cause dental caries. Salivary flow and pH. The flow of saliva helps to dislodge microbes from the teeth and the mucosa. So saliva has a positive effect on our mouths. It helps to keep things moving around so that you don't get a buildup of stuff clumped together on your teeth. If you do not have enough saliva, bacteria and byproducts can stick to your teeth a little bit better, causing the possibility of having dental caries or periodontitis. Common medications that cause that are your blood pressure medicines. Blood pressure medicines often contain a diuretic, so they take the excess fluid out of your body. Antidepressants are another category that can cause severe xerostomia. Allergy medicines, like Benadryl, that dry out your mouth. So lots of these can have, they can cause oral candidiasis, or in other words, infection, root surface caries, so decay on the teeth, or excess plaque formation. And the effect on gingival tissue, or overgrowth of the gingival tissues. We talked a little bit about this in earlier chapters. So you have drug-induced gingival enlargement is an overgrowth of the gingiva that is a side effect associated with certain medications. 3 major classes of medications known to cause gingival overgrowth are anticonvulsants, immunosuppressives, and calcium channel blockers. Anticonvulsants are medication taken for convulsions or seizures. Immunosuppressives are medications that patients often take when they've had like a transplant of some kind, an organ transplant. And calcium channel blockers are a category of blood pressure medicines, very common. This is gingival overgrowth from a medication called phenytoin, which is for seizures. It can cause this, now it doesn't cause this on everybody that takes the medication, but patients can get this kind of overgrowth. If that's the case and they need to continue to take that medication, then they can have this gum tissue trimmed away. It will grow back if they continue on the medication, but sometimes that's as good as it gets. Patient has to have meticulous home care for this. Immunosuppressives, again, these are for patients that have had organ transplants. We don't want the immune system to respond to the artificial organ, and so in order to keep it from attacking the new organ, they will suppress the immune system. It's called, medication is called cyclosporine. It's the most commonly used one, and you can see how thick it has made this gingival tissue. And calcium channel blockers. Calcium channel blockers are a category of blood pressure medicine, coronary vasodilators used to treat people with hypertension, angina, and cardiac arrhythmias. So it doesn't happen on everybody that takes the medication, but usually you'll start to notice it in the interdental spaces like this, where it's looking kind of thick. Oftentimes, since there's so many blood pressure options out there, the medical doctors can work with you on changing the medication. But if they can't or won't, then you just have to work with the patient on good home care. And if it becomes too thick, then they can go in and trim the tissue back, and it'll grow back, but at least it takes a while to grow back. Implications you need to know: be alert for medications that can alter biofilm composition. So when you're doing your medical history and you're looking at the medications the patient takes, after you've had pharmacology, you should have a good idea of which ones are calcium channel blockers. And so when you see the health history, before your patients even open their mouth, you should have this red flag in your mind to be looking for thicker gingival tissue, just in case. Educating the patient on it. Stress meticulous self-care. So educate the patient on the type of medication they take and how they should be meticulous with their home care so that they don't have too much plaque buildup. It's hard to clean around those thicker gum tissues. And so, not that it can't be done, but it requires very meticulous self-care. And if a patient is not educated enough on it enough to know to be really good with their self-care, they might not be. And that concludes our discussion about risk factors.